Andy, after my trip over there to visit you guys at Little Rivers, the number of people who I've met who are from the Bradford area, it's just been unbelievable. It's just like every day I meet someone, they're like, "Oh, I grew up, whatever in Bradford or one of the neighboring towns." And so
Oh, wow.
it
Wow.
doesn't seem like a large population, but I guess the
No.
diaspora must be large.
So, yeah. Well, thank you so much for being there and presenting. We very much treasured your time. And yeah, it's funny how so many connections there are, even from these little areas in Vermont, and how they span out there.
Well, it was an inspirational meeting of a group of people that are clearly super dedicated to delivering the services that you provide and really just worked so hard to get through the last few years. So um,
Yeah, passionate group.
it was special to be there. So thank you.
Mm. Well, it's very much appreciated.
We're getting a good amount of folks. I see Dr. Mahoney, Elizabeth Hunt, hello. Going through the members of the Michelle Weed is on. I think Michelle is on the other committee that I'm getting it confused. It's good to see you, Michelle.
Thank you. Yes, I'm on the other committee. I'm just observing.
Great. It's great to have you here. Thank you. I see Jeff McKee. Andy Barter. I think we're getting, there's Rick. I think we have a good enough group here to get it started. I like to start on time. I know I'll let folks trickle in, but I think it makes sense to call this meeting to order. Welcome everybody. I am Susan Barrett. I am the Executive Director of the Green Mountain Care Board. I'm also the chair of the Green Mountain Care Board General Advisory Committee. So I want to welcome everybody. One thing I do want to mention, I believe we've introduced all new members, but Kristen and I were speaking right before this meeting, and we just wanted to make sure that we announced that Sandy McGuire is part of the General Advisory Committee now. She took over as CEO of the Howard Center from Bob Bick. So she is taking his place, and I don't know if she's on yet. I don't see her, but I believe she was here last time, but we weren't 100% certain. So we just wanted to call that out again. So my first order of business is that I'm going to turn over to Chair Foster, who's going to give a high level update on the regulatory work that the board has done since last time we met.
Thanks. Can you hear me okay, Susan?
I can. Thank you.
Okay. I'll keep it pretty quick and high level. ACO, sorry, weird message. I forget all this stuff the minute it's done, so I'm a little off memory, and I apologize if I don't have it exactly right. But the board finished its rate review decisions in July, I think it was, for a small group and individual. They were simply painfully high. They were probably between, I think it was about 13 and 24% is where we landed. And we ultimately felt they were necessary because of the solvency issues that the insurers were having. They're very serious and very concerning, and they required us to give rate increases that we really didn't love. But we had to, and that's what happened. We received a lot of feedback on those. And then next we had the hospital budget process. We had kind of two processes this year. One was the hospital budgets themselves, and then second was enforcement considerations for 4 hospitals. On the hospital budget decisions, they were generally pretty consistent with guidance in that most of the rate increases were around inflationary levels, which had been set forth in the guidance. And then in terms of NPR increases, they were somewhat above guidance. Generally speaking, the board gave higher NPR to hospitals that were able to show either better productivity or if they were lower priced and weren't really high priced. We were pretty mindful of the fact that NPR is utilization times price. And so you really got to be pretty careful of that balance given all the challenges the state has with insurer solvency and affordability. Then we also had enforcement decisions that we had to make based on fiscal year 23. Our guidance is any hospital over a 1% threshold can be reviewed or should be reviewed for whether or not it complied with the budget order. There are 4 hospitals, I think it was NBRH, Porter, UVM, and Rutland that had that trigger. The board did not take action on Northeastern. The board did not take action on Porter. The board enforced half of the overage as to Rutland over a 2-year period. And the board enforced full on UVM Medical Center over a 2-year period. And if you want sort of the analysis or thinking behind why those decisions landed where they landed, the board's budget orders and enforcement orders are all posted on our website, or we can send them out to advisory committee members if they're interested. The way the board enforced was not to take any money back from the revenue that was generated, but rather to lower the commercial price. So if you asked for a 4% commercial price increase and there was an enforcement of 4%, it would be 0 overall, rather than actually clawing back the revenue itself. And then what was the last one that was up there, Susan? I saw 3.
Just to let folks know, we're starting with our ACO process now. We just received the budgets at the beginning of the month.
Yep. And this year we'll have 3 Medicare only ACOs, which is a departure. I think last year we only had 1, I think.
Mhm.
And so 3 this year, and then also One Care Vermont, which I've not looked at the schedule, but that will be coming up.
Great. Thank you, Chair Foster. Really appreciate that. And if folks are interested in looking at any of those decisions or any of the press releases, if you can't find them on our website, please reach out to me or Kristen and we'll make sure you get those. I know we sent the press releases when they went out. You're on our list, but if you need any help finding any of that, please reach out. Great. Okay, so the next item. Oh, I think I see a hand. I think it might be John Macy. Go ahead.
Hi, guys. Thanks. Can you hear me?
Yes.
So I just have a general question for the board. How do you consider the UVM network hospitals like Porter, CM, Central Vermont, et cetera, when you look at their overall financial picture? They're all submitting separate budget requests, but it just seems to me like it's all one big animal.
Hey, Dr. Macy, it's Owen. I can try and answer that. So the statute requires us to review each hospital individually. So even if they're part of a network, they are reviewed as individual hospitals. And then this year, there were factors that can relate to the network status. So for example, like the hospital health, the health of the hospital financially, there were some considerations in the budget decisions that related to some of the factors about how much money was being used where and for what purposes in connection with the network itself. But we follow the statute that says you have to make individualized hospital budget decisions.
Thank you.
Great question. Thanks, John. Okay, any other questions or clarifying questions? Great. So the next item on our agenda is Act 167, Next Steps and Feedback on Transformation. So we've laid out a few questions here. I'll tee them up and then we'll walk through each of the questions. So the first question is, what input do you have on Oliver Wyman's recommendations for GMCB listed below? Let me back up here as a reminder, because we are living and breathing this, so I want to make sure that I ground everybody. Act 167 of 2022 was passed by the legislature and asked the Green Mountain Care Board to use an expert to look at our healthcare system, our hospitals in particular, regarding the health and sustainability of the system. There's a lot of other things that were in Act 167, but I'm kind of focusing you on this now. I know we've talked about this extensively at several of these meetings. So the recommendations in the final report from Oliver Wyman and Dr. Bruce Hammery came out on September 18th. If you haven't had a chance to look at the report or watch the presentation, I'd highly recommend it. It is on our YouTube channel. The report was also linked in the agenda. So the first question we wanted to put out to this group and get some input on is some of the recommendations that the Green Mountain Care Board was given as part of this final report. And I will tick through these right now, and then we'll open it up to the group, and then we'll move on to the other areas of discussion. So the first, and again, these are specific recommendations given to the Green Mountain Care Board. There were recommendations for the Green Mountain Care Board. There were recommendations for the Agency of Human Services, and there were recommendations for the legislature, as well as recommendations for communities throughout the state of Vermont. And so we wanted to start with our recommendations and see if we could get some input from all of you. So the first one was permit no further increases in commercial subsidization for hospital financial shortfalls. The second is to refrain from licensing any further hospital-based outpatient department unit. The third is to simplify and shorten CON process. The fourth is to encourage freestanding diagnostic, ambulatory surgery center, birthing and birthing centers. The fifth is to begin movement to reference-based pricing, ideally at 200% of Medicare or less for PPS hospitals. And the sixth is to require all hospitals to use the same accounting agency and method to construct hospital financials and budget submissions. These are only recommendations. We are, as a board, looking at them, assessing them, just as AHS and the legislature and the hospitals and communities are doing. Again, only recommendations, but I think that your input here and what you all have to share in terms of what you think about these recommendations will help the board move forward or not with any of them. So I will open it up to the floor. And if there's another board member wants to chime in, if I missed anything or wants to add, please do now before we open it up. But I think I covered it.
Would you leave them up though, Susan?
What? I'm sorry?
Would you leave them up?
Yes.
Would you leave them visible?
Yeah. Yeah, that's helpful. Thank you. Thanks, Kristen. Okay, got some hands up. Great. Oh, that's even better, Kristen. I can actually see them now. Sharon Gutlin, I see you as hand number one.
Yeah, and I'm curious with John Macy's input on this discussion. Avoiding licensing any more hospital outpatient departments. The Surgery Center at that is going in by UVM is an outpatient surgery center. And I remember them talking about the cost, and Owen, I think it was you who posed, are you going to be able to provide a cost comparable to more of an ambulatory, not a hospital-based surgical center? And they hesitated. It didn't sound like they were committing to really a significantly lower cost. And I remember reading that you were putting safeguards in place to make sure that there is some constraint. But the difference between the ambulatory surgery center that might be owned and run and pretty much in the surgeons and in like a Dr. Macy and his group versus a hospital is a big difference in cost without any significant difference in quality and outcomes. What do you think, John? Do you have an opinion?
Well, I have lots of opinions. So I think that's a great concern, Sharon. That was going to be my comment was, the difference between number 2 and number 4, encouraging freestanding ASCs, but yet limiting hospital-based outpatient department unit. I don't know if a hospital-based outpatient department unit, what that actually means. Is that the same thing as an ASC? Because otherwise you're saying one thing and you're saying a different thing in 4, refraining from and then encouraging to. So it's going to be very difficult for any hospital to afford an ASC, but yet there is opportunity for that versus some sort of equity firm or VC or HealthSouth or some other big corporate place to come in and put in an ASC in Vermont. Now, I think what this is saying is that there is going to be a better environment to try to get that approved in the state of Vermont. And hopefully with those type of centers, it will drive down the cost of care. We all know that the cost of care in an ASC is significantly less than that same care that's provided in the hospital. And so the more that we can encourage outpatient surgery and even further down the road ASC surgery, the more cost savings we will accrue. So I am a little confused by number 2. Maybe the board could explain exactly what's meant by a hospital-based outpatient department unit.
And we can discuss further. These are recommendations that Dr. Hammery provided, but that's a really good point, John. I think getting clarification on even just definitions of when he's recommending these things to get clarity on that, I think makes a ton of sense.
I think it does make a ton of sense. This is Tom Walsh. My understanding of this is the key difference between 2 and 4 is the difference between hospital-based and freestanding. 2, hospital-based, those, whether we call it outpatient surgery or ambulatory surgery, those terms get thrown around a bit. But if it's hospital-based, it's more expensive than if it's freestanding. And so Dr. Hammery's recommendation was to encourage more freestanding clinics, particularly diagnostic, surgery center, and birthing centers, and for the board to limit the expansion of hospital-owned outpatient centers.
But
So-
Tom,
And could I just add to that the number 2 hospital-based outpatient, that's the HOPD price index, which is substantially higher on the Medicare fee schedule than an ASC fee schedule. So that could be the big difference
That's right.
there. If it's on the HOPD fee schedule, that's substantially more money.
That's right, Elizabeth.
Thank you.
and I just wanted to note that it is a freestanding outpatient surgery center on Tilly Drive. No different than if it were an ASC. So it basically serves the same population, same services, same everything, but there's a substantially higher cost when a hospital is in ownership of that outpatient department unit.
Correct.
I just want to make sure the board understands the difference and the benefits of one over the other.
Thanks, Sharon.
Yeah, thank you, Sharon. I think Dr. Hemery was trying to highlight that for us as well.
Now, I'll throw another interesting wrinkle in this ASC. If Copley Hospital were to put up an ASC across the street from the hospital, but it was on our footprint, we would be able to charge and get reimbursed on our critical access status. If we build an ASC next door to our new outpatient clinic in Waterbury, it's no longer considered part of the Copley Hospital footprint, and our benefit of being a critical access hospital goes away. And so it's actually even cheaper to build an ASC off campus than it would be to build it even next door. So it's driving the price down even more.
Thanks, John.
And one other thought with this is the more that UVM builds in like this with this outpatient surgery center, the less opportunity there is for ASCs to have an interest in doing business in Vermont.
Not necessarily. Maybe in the Burlington area, in Chittenden County.
Thanks, Sharon and all. I'll go to Kathy Mahoney, Dr. Mahoney next on my list.
Thank you. A few things. First of all, I want to say thank you that this report is a bit beefier than what we've looked at in the past, as far as having done some basic research into the current state of things. That being said, I did a quick look at the company, and I don't see that they have a lot of experience in healthcare, and I sort of got that impression when I looked through the report. Because the report does a lot of things that other similar reviews do in healthcare, and that they work almost on an assumption that what we provide for patients is actually what we need to provide for patients. And that's a given. So it's sort of like if you're trying to sell T-shirts, everyone assumes that you want to sell T-shirts and someone wants to buy T-shirts, and that's the model you're trying to fix. So that makes it easy. But in healthcare, we have a lot of doubts about, is all the care appropriate, necessary, efficient, and timely? So some of this report really does not get into that part of it. So that, qualifying and disqualifying thing comes to mind when I first read these materials. But the other thing I noticed is that all 6 of these bullet points are verbs. They're all actions, right? They're asking, should we do this, 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 and this? And without actually understanding better why the consultants felt that these would be somehow helpful, I really don't know what to say, except a few of them I have a reaction to it. I'd like to share that, some of which you've already talked about. In listening to the group just discuss this, it seemed that we are again talking about cost and expense as if those are the same things, and they're really not. So the cost is, what does it take, say, to do pick knee replacement? That's easy to pick. So what does it cost to do a knee replacement? Now, whether you do it in facility A or facility B, the expense to the state of Vermont and to the health plans may be different. But really what it is the cost. And I'm not sure that changing the setting of where those things are done is going to do really anything in the long term, except in the short term, it will allow us to bill more efficiently or get paid at a better rate. So I'm a little reluctant to get behind any of those things that simply change the venue of where we're providing the service to our patients. I think that all these need to be looked at and see whether there's a patient devised reason for them or a care's devised reason for them, and then an expense devised reason. The number 4, of course, being clinician, really pushes some buttons for me. And I have experience in all of those 3 areas. And again, I think that, if I look at freestanding diagnostic areas, I'm not sure what that entails from a funding perspective, from a staffing perspective, from a logistics. I know what an ASC is. I've worked in them many times. And again, I think that the advantage of them is they sometimes seem more efficient in their operations. But why can't we make our existing structures that we have function more efficiently rather than think about a build out of yet another building? And then, of course, birthing centers is a topic near and dear to my heart that I think frightens me, frankly, because if you really want to do that safely, the staffing, I think, makes them unaffordable, which is why many places have closed the birthing centers that blossomed back in the 80s. So you still need to have an obstetrician, you still need to have anesthesia, you still need to have staffing and ability to take care of disasters that can happen. So I'm not sure where that came from, and I'm curious where item 5 got its information from. Thank you.
Thanks, Kathy. I think Walter.
I just wanted to say the reference-based pricing would make it so that the place where you get a service wouldn't matter. So in other words, if you get it at the hospital in Burlington or you get it at Copley, if it's reference-based, at least close, it could take into account some variables of the location. But I think reference-based pricing is a good recommendation.
And Kathy, I guess I should have answered your question in terms of this recommendation 5. This again is Dr. Hamre's recommendation, and looking at the goal of his work in order to provide those essential services in our communities and sustain rural hospitals, among other things. This was a proposal he put out, a recommendation he put out. We at the Green Mountain Care Board are doing a study right now that was asked for us to do last year on a small study on reference-based pricing for the VHI, the Teachers Health Benefit Program. So that's will be, not that we're doing a full-fledged study, but that will start some of the investigation. And thank you for your comments, and this is super helpful for us as we tick through this list. And again, none of this is going to happen overnight, if it happens at all. These are just recommendations, but I think it's a really important discussion we're having and really helpful. Thank you.
You're welcome. I just wanted to briefly add that item number 6, I really like the fact that, it's been mentioned to have some standardization of, this is at least financial reports, which I think is wonderful. But I also think that having the clinical piece aligned is very important as well, so that there's one language spoken in the medical record.
I just had one thing, is that Oliver Wyman has a ton of experience in healthcare. This is what they do. It is a healthcare. The group is a healthcare group, and Dr. Hamre is a clinician and has been advising on these types of projects and running a hospital for many, many, many decades. The firm does a lot of other things, Oliver Wyman, but they have a healthcare and life sciences group. Dr. Hamre has worked in Vermont quite a bit as well. He did a lot of the COVID work, and then he did the wait time study. I just
Thank you.
wanted to make
Yeah,
sure that
thank you.
was
I didn't see
clear.
that. I didn't, when I looked at their website, I didn't see healthcare as a big thing. I must have missed it, but thank you.
No, they're one of these big consulting firms that does a lot of everything, I think.
Think so, and I meant to get to that too. He's also an infectious disease physician. So, okay. Any other questions before we move to Walter?
I'm eager to hear from Walter, but I wanted to thank Kathy for her comments, but did you have questions, Kathy? I thought I heard a couple questions and I didn't know if we responded or not.
So, thanks, Tom. The questions that I had, and it may be in the reports, I didn't have a chance really to go thoroughly through them, but I was just curious where these 6 recommendations came from. Like, what was the process? I mean, how do we get to that point? And I don't want to take the whole meeting in that regard. And part of me asked it in a rhetorical way, just to say that was my initial reaction to that, as I said, oh, that sounds interesting. I wonder where that came from.
I see. Okay. Yeah, I'm not sure if this is the appropriate setting to go into more detail, but we ought to be able to answer that question crisply. And I think it's important to understand that the 6 recommendations are meant to try to rein in the rapid growth in commercial prices that we've seen in Vermont over the past few years, that are associated with hospital services. So if there's a way to move care safely and efficiently outside of a hospital, that's part of what's underlying these recommendations. And the other thing that's underlying it is, as a regulator, can the board should consider capping not only the rate of growth, but the actual prices that are being charged by hospitals. They've grown very fast in Vermont, far outpacing the rest of the country.
Yes,
And at this point, they are among the highest in the country in just a few years. And so that's at the root of this.
yes, I understand. I'm a consumer and an observer as well.
The process was Dr. Hamre had essentially 4 sets of recommendations, one for the legislature, AHS, Care Board, and then hospitals, right? And so this was the set that was particular to the Care Board. And I don't know exactly how each one came to be because he was off working on his own. But I think a lot of it came to be from his experience having run Geisinger and having interviewed and spoken with tons of hospital executives and looked at our data. And I think it's sort of a collection of all of that information is what he put together here. The question to him was, what should we be doing differently at the Care Board? And this is not an exhaustive list, as I'm sure you all know. There's many others. We could probably have a lot of pages, but these were some of the ones that he thought were most pressing for us to consider at the board, which is why we appreciate you providing feedback on them. Walter, I think you were going to go.
Yep.
I've been waiting, Owen. This might be kind of a stupid question here, but is number 1, exactly what does that mean?
That's stupid.
Yeah, no. I think that go ahead, Owen, because I think it goes to what Tom was talking about too, but go ahead.
Yeah. So, I mean, if you look at historically, the budgeting process with the Care Board has been how much money are you getting from Medicaid? How much are you getting from Medicare? What are your expenses? And in some ways, solve for X. And the solve for X has been a commercial rate increase. Now, that's not like across the board with every hospital or every year. It's kind of a gross generalization. But I think what he's getting at is that because of the financial situation hospitals are in, and because of the projections, we can't continue to use commercial rate increases to solve all of our problems. He said quite a bit that hospitals need to run their operations based on Medicare and to try and target a Medicare cost base, which means you need to break even on Medicare, because we can't keep going up at the level we have on commercial.
Does that answer your question, Walter?
Semi, yes, I think, and Tom, Tom had the next part of my question about either capping or regulating hospital prices. And the third point that comes out of that in commercial subsidization, et cetera, is that it's our rates that are subsidizing it. So I think that's one thing we need to think about it. And these hospitals seem to think they can get whatever they want, but that's another story.
Thanks,
I'll
Walter.
drop it there.
Thank you. Great question. Never a stupid question, Walter, from you, from anyone. Jeff McGee, I see you are next.
Thank you. So a couple of comments and then a follow-up question actually on Walter's. So, all of the recommendations made in the report, I think, are predicated on the idea that all of the existing supporting services, non-hospital-based healthcare services, are going to be here and be in place and be able to continue to do what they're doing today. I think, just speaking for FQHC-based primary care, I think that's in question as to whether or not the sustainability of the system of care outside of the hospitals is assured. And so I encourage the Green Mountain Care Board, even though it's not the focus of your purview, to increasingly be concerned about the solvency of the rest of the system that supports all of these recommendations being even remotely achievable. But to follow up on Walter's question on that first one, permit no further increases in commercial subsidization, just to highlight how that, I think you all get this, but to put it in real terms, we just got our premium increase from our health insurer for our employees. It's going up another 19%. That's talking them down from an initial quote of 26%. That'll make our 4-year increase in our health insurance premiums for our employees over 60%. Right? And so, again, to my point about the solvency of non-hospital-based primary care, that's a huge hit for us. And living in the shadow of a hospital that's had some of the largest increases, that directly drives those costs that get passed directly on to my organization and all of my employees. But the larger question, I was looking at number 1 here and tying that back into Chair Foster's opening remarks around the increases to that were granted, and some of Member Walsh's comments around some of the challenges here. Okay, we can all agree to one. How do you do that? How do you? I mean, it doesn't seem. I think if you've been trying to do that, I think, for quite a while. How are we going to change that? I'm at a loss to say, we all agree with it, but how do you get there?
So two things. I think your point about the rest of the system being there, part of this is to ensure the rest of the system is there, is part of the reason for some of the recommendations. I know it's not like focused on how do we sustain the rest of the system, because that wasn't the legislative task. But certainly, if you look through the recommendations, a lot of them are with an eye towards exactly that. And then in terms of like no further hospital commercial subsidization, I don't know that we've necessarily been trying to do that for 10 years. I think it has been changing over time. I mean, certainly in 2023, the board gave a 17.4% increase to Rutland and a 14.77% increase to UVM, and a 10.1% increase system-wide. What was your increase in 2023, Jeff?
23, I think we were at 18% in 23.
I mean, for how much more commercial insurance paid as community health centers?
Sorry. Our premiums went up 18%. How much did we collect? A fraction, low single digits increase in our rates. Yeah.
Elizabeth, same for you guys?
Yeah, I think we're at 3.2%. Whatever right. Medicare went up.
Right. So huge disparity between, 2023, what an independent surgery center and a FQHC received as compared to two of the larger hospitals in Vermont. And then in 2024, I think system-wide, the rate increase that the board approved of 4.1. And I think in 2025, system-wide, the care board approved was about 3-ish, 3.4, 3 to 3.4-ish. And I know in the last 2 years, what the surrounding supports have received in rate increases has been more in line, right? It's not a fraction of what it used to be. It's more in line. So I think we have been working and pretty mindful of number one. Now, you're right. On the hospital side, when you do that, if you don't give 10 and they ask for 10, there's really hard and tough decisions that are part of the reality on that side of the equation. So if you read our decisions, we've been pretty careful to try and find, where there's waste or opportunity. Maybe it's better clinical efficiency and productivity. Maybe it's turnover time in the rooms. Maybe it's, support for other hospitals, whatever it might be. So that is exactly what we're trying to do. And you're right, it is walking a tightrope at all times.
Thank you. I appreciate that.
Thanks, Jeff.
Could I just, for a second, highlight something that I heard Jeff say, and I want to make sure that I heard it correctly. It sounded, Jeff, as though you were telling us that the cost of healthcare for your employees has grown so much, so substantially, that is a threat to your healthcare providing business.
Yeah, that is one of the threats. I think the other is what Chair Foster referenced, which is our rates not keeping pace with the cost of doing business, particularly here in Chittenden County. Yeah, those are the two big ones right there. Our rates are not keeping pace, and the costs are going up 60% across 4 years.
I just think that's so important because there remain people in the state who provide feedback to us that their response to the work we're doing is that we're overly focused on affordability, that affordability is not really a problem in Vermont, that the qualified health plans that we regulate only pertain to tens of thousands of people, not even a fraction of the population. And so our focus has been off. But I think that misses the point of what's happening to our small businesses, and particularly what's happening to independent healthcare providers as businesses.
I'd be glad to go into another venue or another conversation, but the cost or the amount that we're attributing to uncompensated care, the more that we're writing off bad debt, people who are not paying their co-pays and premiums, also skyrocketing. And so the shift of those to the commercial insurers is not borne just by the insurers, right? It's borne by mission-driven organizations like FQHCs, which don't turn away people because they can't pay, ever. And so that falls directly on us increasingly.
Well, that's important for us to be reminded of. I appreciate you bringing it up.
Yeah. Thank you.
Thanks, Jeff. Thanks, Tom. And I see Elizabeth is next. Elizabeth Hunt.
Yeah, thanks, Susan. I'll second a lot of what Jeff was just sharing as well, that although I run Green Mountain Surgery Center, and so I'm very much into the freestanding ASC. We're not an FQHC, but we also are seeing a skyrocket in bad debt. We don't turn away anyone that can't afford care. And we're just seeing people can't afford it, and people are still coming in where normally this is kind of the heyday for free healthcare. Deductibles are met and they're coming in to get their services. That's not happening anymore. People have a $10,000, $12,000, $15,000 deductible. They can't afford their healthcare. So I'm seeing that as well. And second to that, this past year, so the 2024 plan year, we had to move to Cigna as a payer. We always had either MVP or Blue Cross offered to our employees for healthcare benefits. Cigna, as everyone probably knows, has an issue with prior auth, so we've always tried to steer clear of that, just so then we can make sure that our employees get good access to care without the burdensome of PAs blocking them. Because of year over year 22% increases, we would have been at the 66% increase over 3 years if we stuck with Blue Cross Blue Shield. So we're in a Cigna plan this year because they're based off Medicare. So their rates don't increase substantially, and it's affordable for us. It was just not affordable. So we took on the burden of covering that 22%, the additional 22%, and then we said, we got to cut it off somewhere. We can't keep doing this. The expense was just getting so high. So we're on a Cigna plan now, which is much more affordable. And truthfully, the PAs aren't nearly as bad as we thought they were going to be, which is good news. But it's much more affordable for us as an employer. And just, of course, we know that that's one of the payers that are not looking for rate increases yearly. So that's something there. And talking about Act 167 and the whole basis of this report, and then when talking about Act 167 stabilization and trying to encourage freestanding ASCs, diagnostic birthing centers, again, it goes back to something Jeff was mentioning, that it's just the sustainability of non-hospital based providers. There's Section 6 of Act 167, that part of the Blueprint for Health, Section D8, mentions specifically promoting best practices regarding patient referrals and care distribution between primary and specialty care. I don't think that there is kind of that encouragement of pushing care, regardless if we're talking about financial or physical access to care. I don't think, and I've personally experienced and have had many patients reach out to me to speak about this. You're coming for a carpal tunnel and you're going to one of the hospital networks. You're going to be referred internally. And if you ask for an external referral, you're going to be blocked unless you push 2, 3, 4 times to get an external referral, which most likely, based on all the pricing that we're all talking about and the stability of pricing, most likely you're going to be outside of that hospital-based practice. So you're going to have a cheaper balance. You're going to have probably a shorter wait time. So I do think that although there's so much work to be done, and I know you guys are working really, really hard on all these things, and they are very much all connected. I do think when you get down to it, when you're speaking of hospitals versus independents, those are so far apart right now. And the stability of independence, and especially with the consultants are saying to encourage this to happen. And as we spoke about, not having it a hospital base for HOPD, and just allowing access and stabilization and diversifying our healthcare system. We really need to, I think, look at what's keeping that so far apart right now, because those referrals are being kept internal. You'll be on a wait list for months and months and months. When I actually spoke to a physician who is a hospital-based physician in Chittenden County, and they were floored that they weren't allowed to refer out without specifically having to go through some loopholes to refer their patient outside of the network. So that's a big issue.
Thank you, Elizabeth. Thank you for sharing.
Elizabeth, were those loopholes within that organization or by a payer?
Within the organization.
So, thank you.
Okay, John Macy, I see you're next.
Well, Liz, so many good points. I think that I have experienced exactly what you have just said about personally and professionally going outside the networks. It's extremely difficult, it's cost prohibitive, and it really does limit access to care. And I think that's a real issue. I just wanted to just really congratulate you guys for number 3, at least his recommendations of simplifying and shortening the CON process. Having gone through that with just trying to build a outpatient clinic, it can be very burdensome. Now, I also would like to thank you all for giving us a CON in 45 days, which we thought was a miracle. We thought that was going to be the rate limiting step in building a building. It was extremely short, relatively so, but it was still very expensive. And that increases the cost of any building process. So simplifying it and shortening it will definitely help. And that will encourage some freestanding diagnostic ASC birthing centers. My question is, they recommend closing several different hospitals' birthing centers, but yet encourage opening freestanding birthing centers. And I'm not really sure how they are thinking about doing that, or how that's going to happen, because opening a freestanding birthing center is not going to happen.
I'll just chime in here too, just as a reminder, these are recommendations. And I think that this is just the thing that we need to do with all of you. Hospitals need to do with their communities. My next point is the Agency of Human Services is leading the next steps in these discussions and feasibility and exactly what you're saying, Dr. Macy. Like, does this make sense for what we're trying to get to? More affordable access to high quality care. So thank you for that.
I'd also like to say that, the birthing centers, particularly at some of these smaller hospitals, are huge centers for loss of finances,
Yeah.
loss of personnel, frustrations with the scheduling of making these efficient. They just don't work well. They're not busy enough. They're not designed well enough. And they're really burdensome on most small hospitals.
If anyone has input on what changes they would like to see to the CON process, please send them to us. That is something that I support quite a bit. We've been trying to speed it up for particular projects, and I'd like to change the thresholds fairly significantly. So if anyone here has recommendations, please send them.
Thank you, Foster.
I see thumbs up. Okay, so let's see. I think Sharon, you're next. Dr. Macy, were you done? Sorry.
Yeah, go ahead.
Go ahead, Sharon.
I just want to echo John and Elizabeth's experience with the hospital UVM in keeping referrals in-house. I mean, we've had patients that have come to us as a provider, and we will refer to Tilly Drive, and they'll go into surgery, and then they'll be put in, instead of coming back to their provider within our practice, they will get automatically put into outpatient physical therapy within the hospital's ownership. And patients have come back and have apologized for not coming back, but they were told they can't. And then a personal experience, I called up my colleague friend at Tilly because I had a knee injury and I wanted to get in. And imaging was 2 months out, and then to get in to see an orthopedic surgeon was like a little bit past that at 3 months. And then I just went to Evergreen Family Practice the following week. I had imaging within a week and pretty much was treated and made well even before I would have been able to get in at Tilly Drive. So there is, I think, opportunity to pretty much put conditions on hospitals to help patients to get the care, even if it means not with them. I mean, I certainly would not stop or interfere with a patient going to another business if I felt it was better for them. It just seems like that's common sense. The other thing important to recognize is that not all disciplines have been reimbursed at the same increases. And within the physical therapy businesses, looking over a 15-year period where year-to-year inflation is over 40%, our rates per visit on average have only gone up 10%. And so you can imagine the discrepancy with the expenses far exceeding any increase that we get. So when Blue Cross Blue Shield, for instance, I finally negotiated them up from a 3% to closer to a 10% last year well, it actually ended up not happening until April. We have to play catch up. We lost a lot of our providers to the hospital, to other states, because we couldn't afford to increase their salaries. So we have catch up. It's not enough to suppress the payments to independent providers and then just say, oh, well, you're getting the same as the hospital in like a 3 or 4%. We need to get to, I'm not expecting a 40% increase or 30, but we have to recognize that independent providers need to have accelerated rate increases to get to the level of which they can hire, they can do repairs, basically function again as a sustainable business. And the other thing to remember when you're dealing with the rate increases with insurance providers is that they may tell you a different story, especially like an executive session. I worry about this because an average rate of increase based on codes that we don't use meaningless. So I think it's important to somehow have the board have access, at least I am willing to provide access to the average payments per visit. For our practice, it's relatively simple, much simpler than like a primary care doctor's office. And that would help you understand how we're slipping away and we're in a critical state at this point. And our increases with Medicare and Medicaid have actually gone down. And so we aren't getting the same rate increases. Like if you see rate increases going up for one provider group, don't assume it's across the board. And one other thing. Well, if I'll remember, I'll raise my hand again. Thanks.
Thanks, Sharon. I see Rick Dooley is next.
Yeah, so first of all, regarding the con, I think, Owen, you've already heard from Health First. The Health First strongly supports raising those limits significantly. I do think it's super important. The recommendations taken as a whole are very much in alignment with what Health First has been saying for really the better part of a decade. A number of us have been saying this for a decade, that hospital-based care is expensive. Hospital-owned care, even if not in the hospital, is expensive. Independent practices tend to be cheaper, and we're not getting the support we need. I just want to sort of echo what Jeff McKee and Liz Hunt said about the the strain on practices. We represent smaller independent practices across the state, and the strain on them for providing health insurance, providing benefits for their employees with this sort of never really increasing reimbursement is a huge issue. I won't go on beyond that because I've said it all literally for 10 years. It is nice to see a lot of the things we say in print from an external source, though. The only other thing I would say is that one of the concerns we do have is if some of the recommendations are taken without others, we worry it could actually worsen the problem. So, for example, if the con process is improved, but there's not a shift to trying to encourage freestanding diagnostic ASCs and birthing centers, runs the risk of just making it easier for the hospitals to, sort of multiply some of their resources and still be very difficult for some of the other resources, the other independents in the state. So there's something to keep in mind. But thank you for this.
Thanks, Rick. And I see Kathy next, and I'm just mindful of the time. We have a couple of other questions, but this is super helpful. I'd like to keep the discussion going if we can. So Kathy.
Yes, I'll be brief. I just wanted to echo, John pointed out some of the questions that I had about number 4, about where did those ideas come from? What drove those? But my question as I was listening to everybody speak and thinking about costs was, and I just don't know the answer to this question, so I'll just ask and see if anyone may have information about it. But do we have an idea as to the billing practices and the companies that provide those services to the various healthcare facilities around Vermont? So, and I'm basing it in part on some personal experience with Dartmouth, and they have a third-party collection system, a company that does their billing and manages payments and things. And so, Dartmouth is pretty much hands off on it from what I can tell. And that adds another layer to the system. And I haven't seen that in any of our previous discussions in this group or in other groups. It seems like it's a little bit of a ghost cost that I never hear about. I'm not saying just here in general, but in healthcare, where does that money go? They have to take a piece of the pie, obviously, to run themselves. But how much of the pie is that? And have their rates gone up?
I think Elizabeth, do you have information?
Yeah, for billing, I brought billing in-house at Green Mountain Surgery Center, but generally, because I've assisted in a lot of physician offices bringing it in-house too, just for accuracy, but also it's incredibly expensive to outsource billing.
Exactly.
Typically, it's between 4, and depending on the amount of management, and to your point, if there's a collections, we don't do collections here, but it's between 4 and 12% of expected revenue.
Exactly. So I think that's a bucket that we need to be mindful of when we're looking at where the healthcare dollars are going.
Thank you. Okay. And I see Andy Barter is next.
Thank you, Susan. I can mostly build on what Jeff mentioned earlier. Therefore I can be pretty brief. The same situation applies here, and particularly to Tom's point with what Jeff cited, with the effect of the rate increases for our health insurance it spans out pretty far. So in our case, this year, it's more than $1 for every dollar that comes in here in revenue goes to the health insurance, with both an employer and an employee portion. It really has a dramatic effect on our ability to provide services, our sustainability, and every employee here. I think that's actually pretty common for any employer in Vermont with 100 or fewer employees, with the very large rate increases that are on the exchange-based plans, and difficulty in self-funding or leverage funding at those sizes, and the end of the availability of association plans. So just a huge impact there for us. And another, same as what is going on, by the way, I'm with Little Rivers Healthcare, FQHC in Eastern Orange County. So we have a lot of, we're a smaller scale than Jeff's agency, but we're pretty similar. Our bad debt this year is up by 80%. We're seeing an increase in patients and an increase in their inability to pay. And that's having a big impact here too.
Thank you. Thank you for sharing. And I don't want to rush folks. This is an excellent discussion. We have plenty of time. So please chime in if you haven't already. And I see Elizabeth is next.
Sorry, I meant to speak of earlier, just regarding the point 1 of permitting no further increases commercial subsidization is something that I've just kind of thought about in reading the report when it first came out, and then hearing reading a few subsequent thoughts on things, is just in general, in any business, revenue minus expenses equals profit. That's just how it works. So if you plan for understanding, and it's not easy, but relatively easy in the grand scheme of healthcare things, to figure out roughly your Medicare and Medicaid population, what will or will not happen as a shortfall in general terms as a percentage. You can then work on your efficiencies, as somebody mentioned, just the importance of efficiencies in healthcare. That is, we are not a business with a conveyor belt. We're not a business with robots, unless you're in the OR. But there's something to be said about the efficiencies and then meeting your budget where it's at. So you can't just name your price and work towards it. And I think that's something that's consistently not really spoken about in a lot of these discussions. Is it's revenue. It's just kind of, that's the number posted, that's it. And I've heard in just through different conversations again that I can't believe the care board cut our, because we took care of more patients than we were supposed to. And well, it's not really what they, as in you all, were regulating, and, you know, to get into the intricacies of that decision, but that it's not saying take care of less people, but maybe there's a different way to approach that topic of saying you need to control your expenses. So figure out your efficiencies, as I believe Owen spoke of, is figure out your turnovers, your efficiencies, your head count, figure out just all those different things that are just consistently happening. And that's just kind of, it's a little bit of a rant, but that is something that I've been hearing a lot of, and people have been coming and talking to me, that I can't believe that their rates, that they can't take care of the population. They want less revenue. And it's I believe it's Kathy that said that that's a really big difference. Revenue, profit, expenses, those are really different numbers. And maybe controlling that expenses would naturally bring up profit without having to touch revenue. It's not about the revenue at the end of the day, if we're controlling, as you guys are doing a great job controlling the overall budgets and costs.
I think that's exactly right, Liz. I don't know if you read our opinions, but that's what they say. So sometimes I think what gets translated in the public discourse has a divergence from what we actually do and why we do it.
Yep, it sure does. No, I didn't read that, but yeah, that's, I was trying to echo that to everyone, that I'm sure they weren't trying to, I know they were not saying take care of less people. That is not the goal here.
Yeah, I think you nailed it.
Yeah.
Thanks. And Walter.
Hi, Sue. Thanks again. As a patient, or what we often call in our business service world here, consumer, I have trouble with healthcare as a business, with costs, profits, losses, revenue, all of that. Because when you figure that into the equation, patient care is what's going to suffer for that. Patient is the source of revenue. Patient is the source of operating costs. Patient is the sort of profit. Too much of that, you lose. So I just have a lot of problem with this whole concept of healthcare as a business. The second question I wanted to ask is, what can we do about some of these recommendations 1 through 6? And I know it's a question that's been asked before. The hospitals and the special interests are going to fight most of them. It's an open question of whether we can even do half of them with the legislature, such as it will be. The insurance companies will no doubt fight the number 1. So I'm just kind of curious what it is we can do about at least some of these.
Well, we're starting here and getting your feedback. And some of these things might have to go through the legislature, as you said, like some of our statute changes. But I think looking at these, listening to all of you, and I think the board, and I don't know if, Owen, you wanted to chime in. I think I heard you. The board itself will look at the recommendations and work with stakeholders and folks like you on how we go forward. But was it you, Tom, or Owen? Somebody wanted to chime in.
Well, I think some of these to various degrees we can just do on our own, and just hearing the feedback and discussion today helps me think about how we should prioritize some of these. But then, yeah, others of these will definitely take legislative action, such as simplifying and shortening the CON process. So we can kind of shorten it and kind of simplify it with our discretion on how we run the process. But changing the thresholds or what's exempt, that takes legislative action. And so I think being very involved in that would be beneficial. I don't know, reference-based pricing or commercial subsidization, those are a little bit different. The same accounting agency, I think that would be really helpful just so everyone understands apples to apples kind of across the board. I don't know if that one takes legislative action or not, but last year was a pretty engaged legislative process. I think this year will probably be pretty engaged as well on healthcare, maybe even more so. So I just think really having the balance of perspectives and inputs from everybody in the healthcare system is the only way to make good decisions, whether it's us at the board or the legislature. So I guess my plug is participate as much as possible so that everyone has a real breadth of information and perspectives.
If I could second that, I think there's a lot in this list of 6 that the board can do. It's difficult to do and often upsetting to hospitals. And hospitals care for and employ a lot of constituents for legislators. So they have a big voice, rightly so, to their legislators. So one thing that would be helpful from you all, read the budget orders and the decisions. We've worked hard over the past few years to make them more accessible to non-legal individuals. They're more readable. And we really go to great lengths to try to lay out our thinking about why we made the decisions we've made. We don't have a lobbying action or a communication team. When we make our decisions, we then have to spend weeks writing it. And during those weeks, there's a vacuum of information that is often filled with incorrect information. So the more you all can understand why we're doing what we're doing, why we're trying to do what we're doing, and be vocal in your support, or if you feel there are things we need to do differently, vocal in letting us know. That's one of the biggest roles that I see for this committee. And so thanks for the chance to say that, Sue.
Thanks, Tom. Thanks, Owen. And Kathy, you have your hand up.
Yes, thank you. I just wanted to emphasize that when you mentioned item number 6, that of the 6 things here that we're asked to talk about today and react to me, that really has the most opportunity for moving the dial on so many of the things that we talk about in these meetings. And the reason is, first of all, it's going to give everybody the same kind of financial language, at least. It will be able, as someone mentioned, comparing apples to apples. That's what this would do. It would allow us to do that financially, not so much us as the members on this committee, but the other folks in the room and in other committees who actually are trying to look at numbers and trying to see, why is this one doing better in outpatient and this one is doing worse in that, from a financial perspective. And it would usually, high cost is sometimes an opportunity for improvement of clinical care and the delivery of the care. But it also will give us a way to measure in the future. So in a few years from now, if we have a standard language around finances, we would be able to measure how that works. Right now, with everybody doing their own thing, it's really difficult to compare across facilities. And then lastly, getting us to speak a common language financially would set the stage for perhaps being able to do that on other things, maybe on supply chains, technology, electronic records, or anything else that we think that as a state can be standardized to take out some of the noise, if you would, in our data sources. So I think number 6, if we were going to back one thing, that's what I would love to see that. Thank you.
Thank you. This also, when I look at number 6 with our staff, we have a very small team that oversees the hospital budgets, 3 people, and this could help in that efficiency on the other side of the coin too. And I will say one of the recommendations for the Agency of Human Services was to look at a single EMR across the state,
Yes.
as you mentioned. So
Thank you, Sue.
yeah, John Macy.
I just have a quick comment suggestion about public relations. I've had so many people come to me and say, can you believe what the Green Mountain Care Board is making us do? And as you just explained really well, these are recommendations by an outside consulting firm. Yet this is not how the public sees it. The public reads this, even well-trained medical folks that really don't have an understanding of this process and, just relate everything directly back to the Green Mountain Care Board. And I think, just sort of communicating to them that really this is communicating to the public somehow that this is going to require the health services agency, these are just recommendations. These are not like coming down the pike tomorrow. And it would really do a lot to sort of quell some of the fear that is out there in the general public.
Thank you. Kathy,
Dr. Macy, can I ask you a quick question on that? Dave Merman on the board. My impression is that most of the general public does not follow board meetings and publications. So where do you think the people that are having these views are getting their information?
So I will qualify that. The public that surrounds me are the medical public people. So my own partners, for instance, a good friend of yours, for instance, that really sort of don't understand the process. So healthcare providers who are major influencers and communicators with their patients really don't have a good understanding of this process.
From my perspective, it's been Digger, 7 Days, and then I don't have social media, but apparently someone was on Facebook talking about the recent decisions. So you guys are getting a lot of press.
Yeah, not necessarily the best.
No, but you're getting a lot of press these days.
So
Thanks.
that was a good one, Dave. Yeah. Like, where is it coming from? I think the press, we're fairly transparent, but I think Dave is right. I don't think the general public is very attuned. We have Walter, obviously. We have our advisory here, and we have folks who do really pay attention to what we do. But this is really good feedback. Thank you, John, and others. Sharon, and we are running up against, now we really are running up against time, and I wanted to get to the last 2 questions, but Sharon and then Walter, and then we'll move to the next question.
Well, I think it was on WCAX that there was a large group of public at the hospital. I'm not quite sure. Was it in Newport? I thought maybe David could talk about it because he was under fire there at the closing, or no, not the closing of the hospital, but transforming it to take on mental health at the expense of other services. And I can understand how the public would be upset about not having access to services within reach. I mean, having to travel a long distance, even for a patient, but for the support people, and for the disruption in the lives of people at work and childcare to go to different facilities. So I will leave it there and let David talk about it. But I was confused because I only heard like the tail end of this.
Well, I mean, my general view is I think that there's been a misunderstanding of what the point of all of this is. I think that my understanding of the Act 167 work was kind of born out of the instability at Springfield and the risk of potential hospital closure suddenly in a region and the devastation that that could potentially provide. And I believe that a lot of the sustainability work in 167 was trying to understand the landscape of hospital sustainability in Vermont and the recommendations from the consultant report, from Oliver Wyman's report that was, you know, the legislature, you know, allocated the Green Mountain Care Board to hire the contractor for, you know, talked about a few hospitals that were potentially risky in their analysis and what plans are that they could potentially use to try to mitigate the financial challenges that they are in. And I think that's a very long, complex talking point that doesn't come across nearly as well as, you know, what was said there, which is the Green Mountain Care Board wants to close our hospital and limit our services. I think that's not the board's view at all. And so I think there was a lot of, and I think in that region, there's a lot of misunderstandings about, you know, what these recommendations mean and the magnitude of them. And I think there's, you know, they have a different view of their financial stability than what was presented in the report. So it's definitely I think there's a lot of room for a lot of discussion. I think the amazing thing about that meeting was that there were like, I don't know, I thought it was more like 300 people just because when I was driving up, you couldn't get into the building. And there was no parking for like at least a half a mile. So, but it was amazing to see that much community engagement and passion for their hospital and access to care in their region and their community and every, you know, living there. And it was amazing and it was beautiful and powerful. So, so I think, you know, I hope we can keep that energy and shift the focus into productively working to improve healthcare there.
Thanks,
That's-
Dave.
Thank you, Dave. It's interesting, right? That the response seems to be fear that the Green Mountain Care Board wants to close some hospitals. When the report was commissioned by the legislature, because the Green Mountain Care Board was afraid hospitals would have to close. It's quite the opposite. And so that's shocking on one hand, but then I look at the news and whether people are having their lives threatened for reporting that a hurricane is coming.
Mm-hmm.
Right? And that the weather people are making, it's a time of a lot of misinformation, a lot of misunderstanding, and a lot of frenetic energy that is directed for personal gain. And our processes are going to be used the same way. We have to be better about our messaging and having our message out the way we want it. But the purpose of that report was to help identify ways to save hospitals and keep healthcare local. And it's somehow being talked about exactly the opposite.
So just to finish up so that I understand and so I can communicate correctly where the board is, it feels like I heard today about this is a report that's just under recommendation. It's not like the board is going to act on it. But it sounded like in the news, which I was pretty surprised with, was I knew that that was a recommendation, but it sounded like the board already acted on it. So my question is this report we're talking about today, already some parts of the recommendation are in motion or not? Was that just truly just trying to get the public's opinion in Springfield? Or is it a done deal?
I think I can answer that. I can answer something. Parts of it are in motion because we're evaluating it at the board and taking steps, right? I mean, it's a huge report with a lot of recommendations. So yeah, part of it is being acted on. We're acting on it today and already and thinking about how we're, going to proceed with how we do our jobs. But in terms of like the hospital specific recommendations, make Copley a center of excellence for orthopedics or have cancer care here or whatever the recommendations may have been, those have not been acted on and they take a fair amount of evaluation and consideration yet, right? And that's where AHS is taking leadership. So there's no fait accompli on any of the hospital specific recommendations. Close inpatient, add birthing, add mental health, none of it. Some of them are ads too. I think part of this, I don't know if I'd go to misinformation. I think it's more of like framing, right? So if you frame to me, I was thinking about this. I don't know how many relatives in Middlebury or Addison County, but a lot. And you said, hey, and do you want more services at Porter Hospital? I would say, yeah. And, do you want to get rid of any? I'd say, no, absolutely not. But then if you talk about, well, your family's businesses or whatever are going to have to pay 20% rate increases and you don't have mental health that you need and you can't get a primary care provider, do you feel the same way? So I think the context matters. The trade-offs aren't part of what's being thought about and discussed. I haven't heard anyone talk about, adding all of these services that align with our aging population. And, the financial component to our healthcare system isn't being discussed around these recommendations. So I think, part of it's framing, a lot of it's human nature, and a lot of it's part of the process, right? When you look at education, Vermont State Colleges, there's a lot of engagement, which is great, and that's part of the process. But no, I think, Sharon, the answer to your question is like there have been no decisions made on the hospital-specific recommendations. AHS is leading it, local communities are making decisions, and it goes from there. And that's how it was always set up.
Thanks, Sharon. And that, I know we're up on time, just a few more minutes. The next question actually is perfect timing. Any recommendations you have, and if we don't have time to get through them now, we can share it with our AHS colleagues. They, as Owen mentioned, per Act 51, will be leading the transformation efforts. And what that means is they're going to look at the report. They're going to be looking at evaluating what it means to communities, feasibility, talking with the community, talking with the boards of the hospitals, and looking at this information. And then ultimately it's the board of the hospitals that decide what's next. As Owen said, we can look at our recommendations and get information from you and other stakeholders on what's next, but it's really up to those communities. So, I know we're really up on time now. If somebody has something quick, please share now, or if you want to email that to us. And we'll make sure that you have contacts with them too, because as I said, we are handing this off to our colleagues at AHS now. So any comments, questions, thoughts?
Owen, were you suggesting that we are not a center of excellence?
I think I was implying the opposite, John.
Okay, thank you. I was just looking.
I was looking at the number of people that are here, and I've never really needed much healthcare in my life, fortunately. And I have gotten healthcare in the last several years from so many of you on this call, and I'm really thankful for it. So I hope we have system-wide sustainability.
Good answer.
As long as I don't need it from Dr. Merman, I'll be okay.
That's right. Any feedback from AHS? For AHS, sorry. And we can, unfortunately, there was, Brendan Krause had the day off today, so he couldn't make it. And, but we may bring them in at the next meeting so they can hear directly from you. But we communicate very closely with them. Jeff?
I guess I would say that the comments I made, I would want to say those same things to AHS, and I'm concerned that their learning curve to come up to the speed that you all are at on these issues is really, really steep. And so, to the extent that we can be at all helpful in conveying those things and the needs and the broader set of needs to them, you let us know how we can be helpful as well. I mean, I for one would certainly show up at a meeting and convey my stories, and would welcome your guidance as to what parts of that are most impactful to people making decisions.
Thank you, Jeff. We will be supporting them in any way we can. To your point, Jeff, we have a lot of data that we can share with them. So we'll do that. Well, this has been really helpful. We do have one more question, but it's 3:30. I just ask you to keep giving us feedback on anything you hear, any suggestions. I know we did have a call to action if, as Owen asked, for any CON changes that you would recommend. That would be wonderful. Oh, and I have to do public comment. Michelle, you actually prompted me to do that. So I will open it up to public comment. So go ahead, Michelle.
Thank you. Sorry.
No?
I was trying to be good and wait.
No, I forgot. Thank you so much.
No worries. For those of you who don't know me or see me in multiple places, today I am wearing my Vermont Nurse Practitioners Association hat as the president of Vermont Nurse Practitioners Association. And for public comment, there were just a couple things over the course of this hour and a half that I wanted to comment on. First of all, thank you, Chair Foster, for saying things need to be put into context, because that is a big part of what I think the issue is. I walked into work one day last week and got 4 people coming at me about this stuff. And I said, whoa, whoa, whoa. It is just a recommendation. It needs to go to the Green Mountain Care Board. Then it needs to go to legislature for the things you're talking about. So take a step back and understand. So context is really important. I do want to go back to early on today. There was the discussion around cost of health insurance. And I just want to throw out there that yet again, and I've shared this in other meetings, but again, it happened to me last week. I ended up admitting a patient to the hospital for a large sum of money because their maintenance medication was no longer prior authorized. And therefore, we now have a $umpteen-thousand bad debt because this person doesn't have money and doesn't have decent insurance that will end up eating at my facility because their maintenance medication wasn't prior authorized. So just throwing that out there. The next thing I just wanted to say was the whole comments about freestanding birth centers, and it was correctly identified. It's Ledge 2, but I mean, VNPA testified on S204 in the spring of 2022. And at that time, we were trying to get freestanding birthing centers because it is a safe place for low risk births, which we should be utilizing our tertiary care for the high risk ones. So it is something we should at least look at again. When we testified, it went through House Health and Welfare, and it was passed to Senate Finance. Subsequently went to the House Committee on Healthcare, where it sat and no testimony was taken, and it died. And then lastly, the question about press. I think I heard a lot of really good things, so I won't say a lot about that, but I do think that what's going out in Digger and what's all over social media needs better framing and needs to have some press releases from Green Mountain Care Board about Act 167, so the general public understands where we are in the step process of what needs to be done. Thank you.
Thank you so much, Michelle. Really appreciate it. Walter.
All right, Sue again. On the press release, Tom is exactly right about the fear. It's a fear of, well, we all know, closing, lost services, everybody's scared. And don't forget, it's political season, and they're whipping up that fear too, against the board, against healthcare in general. I've seen that. I've had people ask me on the street, hey, you shutting down that hospital, you know, and they're all scared and nervous about it.
Thanks, Walter. Any other public comment? Okay, we have listed on the agenda, which was sent to all of you, the dates for upcoming meetings. I think Kristen has also already sent out holds on your calendars. So the next meeting is Monday, March 17th at 2 p.m. My favorite day of the year, St. Patrick's Day. So we will see you all next year. And please stay in touch. And we really appreciate your input. Thank you again.
Thank you.
Thank you, everyone. Thank you.